Good afternoon, everyone, and welcome to the Meet the Masters webinar event series. This is the first of 8 webinars being hosted by the Faculty of Medicine. And in today's webinar, we will be taking a closer look at infectious disease modelling in COVID-19 responses, as well as our postgraduate courses on offer within the School of Public Health and Community Medicine. I'd first like to acknowledge that I'm speaking from my home here in Coogee today, on the land of the Gadigal and Bidjigal peoples. On behalf of the University of New South Wales, I acknowledge Aboriginal and Torres Strait Islander people attending today and pay my respects to elders past and present. It gives me great pleasure today to introduce Dr. Niamh Stevenson. Niamh is an Associate Professor in Social Science in the School of Public Health and Community Medicine here at UNSW. Niamh's research examines the relationships between public health and social and political change, and she's published in the fields of sociology of health and medicine, social research, cultural studies, and qualitative research methods, and is currently researching pandemic influenza and biosecurity. I'd first like to introduce Dr. James Wood. James is an applied mathematician with interests across a broad range from evolutionary and immunological processes to cost-effectiveness evaluations for disease interventions. James has been working tirelessly in the government response to the current COVID-19 pandemic, and he'll be providing a unique insight into his research in infectious disease modelling. Just before I do hand over to James, please make sure that you make use of the Q&A function, which should just be located to the right of your screen. So if you do have any pressing questions that you'd like to address, please feel free to use the Q&A box and they'll be raised at the end of today's session. So without any further ado, I'd like to hand over to Dr. James Wood. James.
Hi, everyone, and thanks, Thomas, for the introduction. So I'm just going to talk to you a little bit about COVID-19 and sort of the work we've been doing here in Australia and sort of internationally. But just to kind of give you a bit of introduction to myself, public health is a really kind of broad array of disciplines, and I sort of come in a bit from left field. I come from a background in mathematics. I'll tell you a little bit about that in a minute. But just to say that, I work with colleagues who come from backgrounds in medicine, health sciences, but also things like psychology, social science, economics, and a big variety of areas. So you kind of come to public health from a big variety of sort of backgrounds, and it's kind of how it meshes with what you do as term as kind of how you move forward in it. So I titled my talk COVID-19 Models, Data in the Australian Epidemic. I'll say a little bit about what's happened internationally as well, but let's start a bit with kind of how I got sort of where we kind of came, the background to sort of coming to here. So just a really big picture backdrop, just in terms of infectious diseases, is that back in the 1970s, there was kind of this perception that infectious diseases were on the way out. So we'd seen, the success of eradication of diseases like smallpox, big successes with other vaccines and treatments and control of mosquito-borne diseases. And at the same time, we were becoming aware there was all these other kind of health issues which were quite important, causing things like cardiovascular disease, diabetes, and so on. And they started to take more of centre stage for public health. And they're still really important, but obviously at the moment, we're kind of back in this notion that infectious diseases are something rather threatening. So I guess, but previously this was challenged by the emergence of new infections like Ebola and HIV in particular, but also kind of changing natures of existing ones like tuberculosis, where drug resistance started to become a big problem. And there's a whole host of other newly identified infections that I won't go into. So, and there was also this growing awareness that while there'd been all these successes in high-income countries, that in sort of lower and middle-income countries, there was still this big burden of infectious diseases that hadn't really been addressed. So I stepped forward to the late 90s, and we sort of entered this sort of new era of concern about pandemics. And it started with an outbreak of bird flu in Hong Kong in 1998. It was only about 20 human cases, but it sort of raised this concern that influenza could spread from animal populations to humans and be really severe. And 5 years after that, there was the SARS outbreak in 2003, and it affected many countries and was kind of like a a forerunner of what we're experiencing today. So both these events led to a renewed focus on the risk of pandemics of respiratory infections. So where do I come into all this? So back in 2003, when SARS occurred, I was studying maths. I was doing my PhD actually in maths at the University of Queensland. And I kind of, I'd followed it out of interest, but I sort of noticed that I went for a ski trip in New Zealand kind of during the SARS period. And I came back on a plane with a very high fever and filled out my kind of travel sort of reports and so on. And, kind of discovered that actually, what you think about how health will manage it and how you experience it might be different. So I came through the airport, I filled out my form, never got checked. I think I probably had the flu, I didn't have SARS, but it was sort of an interesting sort of experience as to how do you actually manage these sorts of things when they occur. So a couple of years later, I'd finished my PhD and I joined the National Centre for Immunisation Research and Surveillance, which is a research centre in Western Sydney, as a postdoctoral fellow in modelling infectious diseases, which was something I'd never done before. But at this time, there was now a new bird flu, H5N1, in the Asia-Pacific region. And this was pretty severe. And there was sort of, maybe 100 human cases in various countries by this point. And there was a lot of concern about whether this might, within months, cause a pandemic that was going to be really severe and might resemble 1918. So, newly into this job, the Department of Health and Ageing at that time issued a tender for modelling support, and a group of us worked on this and worked on models to kind of understand how you should respond to a pandemic. And part of the reason they looked to modelers rather than, say, epidemiologists or other health scientists was because there was very little data. Pandemics are rare events, and they hadn't been well studied before. Okay, so modelling was one of the ways to arrive at answers when you had very little actual hard data to go on. Okay, so just to talk a little bit about what we covered in this, and you can still find the report online. I've got a link to it at the bottom there. It's called a historical publication now, but it's still actually relevant. And what we focused on in that report were things like border control and things like screening of passengers coming in and out of the country. We focused on things like limiting transmission. So all these sorts of things that we've been through and all have personal experiences of recently, like isolation and quarantine and closing schools and workplaces, getting rid of mass gatherings. Use of in the case of influenza, they had drugs, so you could use antivirals also potentially to reduce transmission. And I guess something that maybe hasn't been a huge part of the public discussion, but when you combine these sorts of things, you get multiplicative effects. So one of these things alone might not reduce transmission that much, but if you can do a few of them, you can potentially flatten or squash an epidemic. So that was the report. And I say soft border control because at the time, there really wasn't this notion that we would close borders. We all know that that's not true now, but at the time, there was felt that, firstly, it's really expensive. We don't have even fuel in Australia typically to last more than about a month. And so how would we actually go about closing all our borders? So it was kind of off the menu at that time. So just in terms of what do we conclude from this, we found that soft border controls, things like screening, were not effective. Okay, so a new pandemic would reach Australia quickly. Screening would miss pre-symptomatic and asymptomatic cases. And you could do things around flight-based quarantine, but that would not keep the pandemic out either, although it would be more effective. And local travel restrictions, which Australia is certainly engaged with, might achieve short delays, but weren't considered particularly important in terms of our work. Okay, so we kind of came to these conclusions that you could, if you had drugs to sort of prevent transmission and you use those in concert with quarantine and isolation, so contact tracing, that might be quite effective. Things like school, workplace, and mass gatherings closures would have modest independent effects, but if you combine them, could be quite effective. Okay, and so that was kind of where we left it. But then we had this mild pandemic come through in 2009. So you might remember swine flu, as pandemic H1N1. And this changed a few of our assumptions. So it confirmed some findings. It reached Australia really quickly. It probably reached it before we actually detected it. Entry and exit screening, so soft border control, was ineffective. We didn't catch many of the cases that came into our country, okay? And in terms of a vaccine, we do have vaccines for flu, but you need to match them to the circulating strain. It really did take 6 months from having sequenced the virus to actually having a vaccine in someone's arm. And Australia was actually the fastest country to do this, but it was still well after the epidemic had passed, the first wave of the epidemic had passed in Australia. One of the good things about swine flu, relatively speaking, was that it wasn't particularly severe, or in fact, it wasn't severe in older people. And that was probably because they'd experienced similar viruses when they were young. So after a sort of a month or two of real concern, it became apparent that we weren't going to get this really high burden of mortality and so on. We had sort of had the opposite problem, which was most cases were not visible. So you didn't detect people. They didn't get sick enough to go to the doctor. And so if your strategies around control were to sort of detect cases, so test, then isolate and sort of quarantine your contacts, if you're not actually detecting people in the first place, it's not effective. So that was something we kind of learnt from the 2009 pandemic that changed our sort of approaches. We also learned that risk groups might be quite important. So Aboriginal Australians were at high risk, pregnant women were at high risk. And you often don't know these things before the pandemic strikes, and it's sort of a scramble to learn who's going to be potentially at highest risk and how to protect them sort of live when something's spreading fast. A thing sort of specific to us, what we kind of learnt was that it was really hard to get hold of data. Australia's sort of federal system with the Commonwealth and the states all having their own procedures meant that the only real way you could kind of get data out of agencies was if you had sort of an existing collaborator who already worked in a state or territory health department. So it was a challenge for us modelers to do more than provide sort of general advice in that circumstance. So what's happened since? So in between time, in terms of how Australia has addressed specific features of pandemic responses through modelling, has been things like looking at impacts on the healthcare system. And this was a big focus of discussion for COVID a couple of months ago. I'll get back to that in a minute. Reviews of evidence, and work, I guess, also on what we call forecasting or nowcasting, which is let's take the data that we have to now and in real time generate predictions for what's happening for the next couple of weeks. Okay, and part of setting that up, it sounds reasonably simple in theory, but in order to have agreements with data providers, trial your models and so on, that's taken several years of work, largely looking at seasonal influenza, which is translated across to COVID. So those are things that we did address, but there were sort of blind spots. So particularly there's been, I would say just generally, there's been limited additional work on what we sort of call non-pharmaceutical interventions, but in particular social distancing. So how far away you should stand from people, whether you should prevent gatherings and so on. There was very little work on that in the last kind of 10 years. And in a sense, we've kind of had the scramble to understand those things in the last 3 to 4 months. And I suppose another thing was just things like whether we would consider quarantining all flights to Australia or closing borders just wasn't something that entered into what modelers were looking at in that period. So again, it's been something that has had to be updated quickly. Okay. So some of the reasons for that were just the economic costs. Okay, so even things like school and workplace closures, we've seen it, so I think it's something like 1 million Australians sort of lost their job in a week. So it's very expensive for the economy and also very difficult for people in terms of losing their livelihood. Fortunately, it's been for a short period of time. And I think this, one of the challenges we face in public health and medicine is that we ideally like to understand the effectiveness of things through really high quality studies like randomized controlled trials. But that's almost never possible with things like public use of masks, or how far apart you stand from each other, or whether you ask people to work from home or not. Those things just typically can't be done through these sort of high level quality of evidence sort of studies. And so that meant there was very little evidence around it, and therefore potentially little acceptance of doing those sort of measures initially. And I suppose another bias maybe was just that everyone was kind of expecting another influenza pandemic rather than, say, a coronavirus pandemic as we've got. So if we look fast forward to 2020, it's only 5 months since China basically shared its first sequence of the virus. So they knew what the virus was, they had tests, okay? They still hadn't worked out that this was spreading widely in the community at that point. So a lot changed in 5 months. And in that time, we've learned quite a lot, I guess. So we've learned a lot about the natural history of coronavirus, of COVID-19. So that it takes about 5 days to develop symptoms after exposure, but it can take weeks. That each person on average infects about 2 to 3 other people before you're doing any interventions. And that seems to change a bit between being urban and crowding and climate and so on, but it doesn't change massively. And it's quite severe, but in a particular subsection of the community. So around about 1% of all people who are infected die, but that's sort of misleading because mortality rates are very high in people over about 75 and very low in people under 20. So it's quite a strong gradation with age, and that's made it confusing to sort of say, well, how severe is this thing, and to work out the right sort of policies. There's other things like that it seems to be male gender seems to be associated with higher disease risk, whether that's behavioural risk factors. And in the UK and the US, for example, race seems to be a risk factor, and maybe that's again coding for sort of some kind of disadvantage there. However, children seem much less likely to be infected, to transmit if infected, and much less likely to get severe disease, which has meant that things like school closures probably aren't that worthwhile in terms of disrupting transmission. So what we've learnt about intervention. So one of the simple things we've learned, I guess, is that lockdowns work. Okay, they bring transmission such that each person infects less than one other person, and you kind of squash your epidemic. But lockdowns are difficult because they're, socially and economically really disruptive. So what causes that change? It seems to be what we're now sort of referring to micro-distancing. So that's sort of staying a bit apart, washing your hands regularly, perhaps everyone wearing masks, not meeting in groups, so doing presentations like this virtually. These sort of things seem to be the dominant effect. We've seen, for example, like Google and Apple have produced these mobility reports, which are based on usage of their apps. And initially, the level of transmission was really correlated with their measures. So these, going to workplaces dived massively in March, say. But those have crept back up again as we've opened up in Australia, and it still seems as though our transmission indicators haven't gone in the same way. So it seems to be more the micro scale changes that we've made that are important. And potentially more important, I guess, the changes for adults and older teens rather than young children. 14-day quarantine at our borders, that was really what was most critical in Australia, and I'll get to that in a minute. But you can't do it everywhere. So in the United States or in Europe, it was more challenging maybe to shut all borders. And there's been a lot of talk about testing and isolation and quarantine. I think we do that well now in Australia. And that definitely helps, but we don't know exactly how much it helps. So I've got a couple of complicated figures here, which I'm going to try and explain really quickly. Just to say, we know that people change their behaviour because we did sort of surveys to check it. So this is data from the UK and from Shanghai. And essentially, they're sort of looking at how people made contacts in the community by age before and after lockdowns. And sort of the graphs with the brighter colours, so to speak, are the ones before, and then the ones where it's all kind of a bit flattened out and little variation in colour where after lockdown. And the sense is that people reduced their numbers of contacts across the community by somewhere between 5 and 10-fold, depending on which country they were associated with, China being a bit more extreme and the UK being somewhat in the middle. So we know that this was directly correlated, these changes in contacts, with transmission, with the curve changing direction and going down. So we know that changing patterns of contact really worked. Okay, so I want to talk a little bit about what happened in Australia, and I think the writing on this graph is a little bit small, but all I want to focus on are really the colours. So in Australia, we had some early cases from travellers from China in sort of early to late January, and then we didn't really have anything until mid to late February, and then into March, and then it's sort of our curve just shot up. Okay, and it shot up for two reasons. So the primary one was actually lots of people coming in with the infection from overseas, particularly the UK, the US, and a cruise ship. And then at the same time, however, and a little bit masked by this, there were rises in local transmission. Okay, and that was what was bothering the state health departments here, and that was the specific reason why we went to sort of suddenly all working from home and workplaces being closed and things like that in around about mid to late March. So it's just important to realise, though, that I think still about 70% of our cases came from overseas. So we had much less local transmission than we kind of thought. As modelers, one of the things we've tried to do is track transmission over time. Okay, and I've got three graphs here I'm just going to talk through a little bit. So I think almost everyone's probably heard of this notion of the reproduction number, or R, now. And basically, it's a measure of how infectious each person in the community is at the moment. And it changes if you are reducing your contacts. So if you're at normal for COVID, we think the R value was 2 to 3. And then after lockdown in Australia, so kind of, if you look at this graph on the left here for New South Wales, it seemed to drop to about 0.6, 0.7. Okay, and that all changed in about a 2-week period. So that stayed the same till about the end of May. But since that time, we've been changing our habits. All you had to do was go out on the weekend and see the amount of traffic, see the number of people sort of on foot traffic and people in restaurants and so on, to realise we're going back to normal here. And so one of the things we're looking at is, well, how might that appear to us in terms of cases? And I suppose the kind of message that comes out of that is that there's a delay. So you won't see cases rise for maybe a few weeks after you start to creep over this R equals 1 threshold. So I do have some concerns at the moment. We seem to be almost at 0 in New South Wales and Victoria, but there is the potential for this to kind of start rising again. We're not going to be caught totally by surprise, but we're not quite in the same situation here as New Zealand, which has been able to declare elimination. So a few quick comments about the app. The COVID Safe app was kind of advertised as being something that would keep us safe. It's like wearing sunscreen. And the notion with it is that it allows you to identify contacts that someone might not remember. So if you're out in a mall, you're on public transport, you're at a football game, you might know the people you went with, but you wouldn't know everyone else in your area. Okay, and so if everyone had the app, it would allow the public health authorities to sort of contact those people. And so the app, the notion with the app is it sort of detects other phones by Bluetooth. And if you've got a contact beyond a certain length of time, it thinks that might be dangerous. And so the public health authorities might follow up with you. The issue with it is, though, that it takes, so if I'm thinking about everyone in the audience here, let's say half of you have the app on your phone, okay? That means there's only a 50% chance that you have it and a 50% chance that your contact has it, all right? So actually, overall, it's only going to cover about 25% of contacts. So the app might help a bit, but it's very difficult unless you have everyone using it for it to make a huge difference. What it may do, though, is increase our ability to catch these harder contacts and reduce the time to sort of follow up on them. Okay, so it's going to be of some benefit, but maybe not that much. So just to kind of finish off, I guess I just wanted to say what we're thinking about now in terms of modelling in Australia. So I guess the first thing is, will we reach elimination in all states and territories? It kind of looks like everywhere but New South Wales and Victoria are pretty much in that situation. Maybe Queensland has 1 or 2 cases. Then I guess what aspects of social distancing are most critical to maintain? I mean, what can you maintain while doing everything else, I guess? And I feel like it's probably still trying to keep distances, but I think how people are interpreting the changes back to normal is that they're sort of changing that aspect too. They're changing their macro distancing and their micro distancing together. And there's a few other questions there about how effective is contact tracing alone? How do we most effectively track infection and transmission risks when we have no cases? It's a bit of a challenge, so we're trying to use surveys to find out how the population's behaving. And a big one, I suppose, and one we're all interested in, is what are the risks in opening international travel? Something else that might change how we handle things. Will we soon have effective drugs for treatment and prophylaxis? If for example, that occurs, it might change a lot about how we approach this. So that's kind of where I wanted to leave it for now. I realise we've still got a few slides to go, but I'm going to be here to take questions from people via Q&A. So I might, at this point, pass it over to Neve and allow her to kind of continue with the presentation, talk a bit about public health at UNSW.
Great. Thank you very much, James. Like Thomas and James were saying at the outset, there's a lot of public interest in public health at the moment, and we thought that this would be a good way to open a few windows so people could get a sense of what we do in public health. And like James was saying, we're actually a very mixed crew of people with vastly different backgrounds in terms of disciplinary expertise and also work experience. And I just thought I'd take a couple of minutes to say, give people just a very brief sense of some of our programs, in case anybody is interested in thinking about this in terms of career or career development. So we have an undergraduate program in international public health, and we have 4 areas in which we teach master's programs. So there's a master's in public health, there's a master's in global health, there's a master's in infectious disease intelligence, and a master's in health leadership and management. And they're all 1-year degrees full-time, although most of our students are studying part-time. So all of our degrees you can study either online, and we've been teaching online for over 20 years, or you can come on campus and study as a student on campus. And then there's a whole variety of ways in which people put degrees together. You can do a dual degree in 1.5 years full time, or you can do an extension degree if you're interested in research. And of course, we also have master's research students, PhD students, and an applied professional doctorate in public health or any of those areas. So those are our 4 main areas for master's coursework. And then within any of those degrees, there's a vast array of specializations that you can do in terms of electives. So ranging from health economics through to the kind of modelling that James is talking about, social research, infectious disease, chronic disease. The undergraduate program is going to be, it's running at the moment for students who are studying online externally, but next year we're going to start doing that on campus. A bachelor's in international public health, so public health with an inflection on global health. And yeah, there's a link here in the last slide for anyone who's interested in finding out a bit more, or, you know, we're here now after some hopefully substantive questions for James. If you've got questions about potential study, please ask. And I might hand over now to Thomas, who's going to help fill the questions.
Thanks, Niamh, and thank you very much, James. Really interesting presentation there. And I'd just like to open up the Q&A now. So please feel free, if you do have some more questions for James and or Niamh, please type those questions into the Q&A box that should be available to your right-hand side. So just having a look through the inbox at the moment. So I do have one question that has come in for James. So James, we've had audience participation member ask, how long is it before we are likely to see a vaccine for COVID-19, and how applicable will that be in the treatment of the pandemic?
So I'll have a go at that one. So it's not my specific area of expertise in terms of vaccine development, but it's certainly a challenge for COVID-19. We haven't had an existing human coronavirus vaccine of any type. So there's been a lot of developmental work has had to happen this year. My understanding is that the US vaccine produced by Moderna is going into phase 3 trials soon, which is sort of the point at which we would be able to measure something like efficacy and safety in a large population. So I think they're enrolling 30,000 people. And there's a couple of other vaccines that are getting to that stage. Now, we don't really know if they're going to work. So we have some evidence from, animal models of vaccines having some impact. I guess that the sort of sense from other respiratory infections as well is that the vaccines are probably going to be partially effective. So they might be more effective against disease than against infection itself. And that's, I guess, that notion's kind of stimulated by, I guess, how our vaccines against influenza and so on have performed. It just seems to be harder to create really strong immune responses for these sort of respiratory infections in comparison to something like measles, where your vaccine works really, really well. So in terms of time frame, we could know within, let's say, 3 to 4 months as to whether we have an effective vaccine somewhere in the world. Then it's a question of who's going to get it. So Australia does have a vaccine producer in Seqirus. So if, for example, they end up being able to get hold of an effective vaccine, we could see one in Australia. But there's going to be a lot of issues in terms of producing enough vaccine when essentially the whole world's population is at risk. And I think it's going to create some challenges in terms of equitable provision, in terms there's going to be a rush for those with money, countries with money, to try to get the vaccines first. But I hope we will work out some better way of distributing it once we get one.
It's brilliant. Thank you very much for that, James. I have had another question just come through for you from Jerome. So Jerome asks, looking back how accurate would you say Australia's expert modelling, including yourself, at the start of this outbreak? And what, if any, advancements or changes in the thinking of modelling have occurred or are occurring as a result?
So it's a really good question. I think at the beginning, everyone was guessing to some extent. The first real models and data that came out were sort of work from researchers in Hong Kong who visited the China CDC and wrote a couple of papers sort of at the end of January, that in communication with them, they still feel that the sort of estimates of the reproduction number and the time between cases were reasonable from those studies, although, you know, it's been challenging. Some countries have seen different things. So the early work in Australia was scenario-based. We didn't really know what the characteristics were here. We hardly had any cases. So they were projections of what might happen if we didn't do anything, or, for example, if we had somewhat effective contact tracing, or if we potentially had a degree of social distancing as well. And I think what they were designed to do was, I guess, illustrate what would happen if we didn't act. And I think that's been useful. Essentially, what would have happened if we didn't act was that our health system would have been overwhelmed. And I think the government responded in relation to that. So were those models sort of accurate? No, we're more accurate now. And I think probably the area that we still haven't quite got on top of is just the fact that some people infect a lot of people and many infect none. And that hasn't been reflected as well in the models or in the policy as ideal. And I'm sort of hoping that over the next couple of months, that sort of stuff all starts to feed through, because for responses in other countries, that might be really important. Because they can't sustain lockdowns, but if they can take advantage of some features like that, it might be easier to control.
Fantastic, James. I did have a really interesting question come in from Josie as well. So Josie asks, do you think we are more prepared for future pandemics? And are we likely to see this level of response again in terms of lockdowns, closure of borders, etc.?
Yeah, it's a good question. I guess we've been through a lockdown now. We didn't think we could do it probably before. I mean, that's part of the reason, for example, the UK hadn't actually modelled doing a lockdown until just before they did it, in part because there wasn't a sense that it would be accepted. We know now it can be accepted. But at the moment, I think there's certainly a degree of fatigue over these things, and people, you know, have kind of adjusted to a different sort of level of risk about COVID. We're sort of aware of it. We're familiar with it. We're not all scared of it now. So I think we're more prepared than we were. But if we got a pandemic with different characteristics, you know, something, for example, where if it was more airborne transmission, so, you know, just social distancing might not work as well. Again, we would have new things to learn. So I think there's nothing like a live, you know, serious exercise to improve your preparation. We are better prepared. We have new tools, and we've learned a bit how to use them. But, you know, everywhere's still at risk of second waves, and you're seeing that happening in the US at the moment. So Arizona, for example, cases are rising, and, you know, how are they going to respond?
Excellent. Thank you, James. So we don't have any further questions in the chat at the moment, so I'll leave it open for a minute or two, just to see if we do get any more questions that I can put to yourself or to Neve.
No, I was just going to say, in case somebody is formulating a question, I have a question, James, for you. I guess it's about, my understanding is that there's quite a lot of uncertainty, James, about, you're talking about the, you know, how infectious a person is. And there's quite a lot of uncertainty, and tell me if I'm wrong, about how that might differ if somebody is asymptomatic or pre-symptomatic or actually symptomatic. And I was thinking about that when I was looking at that UK paper that you have on slide 14. That's the kind of modelling paper underpinning track and trace or COVID-safe type apps. And I was wondering if you had any thoughts about the consideration of those, you know, what we don't know in terms of what affects transmission and how that might have shaped that paper, or the presumptions that are being made in that paper.
Yeah, so I mean that's quite a bit to answer in a couple of minutes.
Okay.
So
Okay.
I think and it's been a bit of a public sort of kerfuffle for the WHO about asymptomatic and pre-symptomatic and confusing everyone. I think
Yeah.
we're pretty certain that a lot of the transmission occurs pre-symptomatic. So there's probably a 2 or 3 day period where people have the highest sort of viral load and not really that sick, and they kind of go around and they spread it. Probably also people who just, you know, are symptomatic but mildly symptomatic are quite infectious because they might not change their habits. People who are genuinely asymptomatic throughout, it's really a bit of an unknown. I think the sense is they are less infectious, but there's not really good evidence. And so part of this is about, I guess, these sort of notions of everyone wearing masks because you might not know if you're infectious or not. So, and that's sort of why lockdowns work, because it's not dependent on your status. You're cutting your contacts regardless of your current status. The notion with the app was, it was kind of, that paper was about trying to bring down the time to find contacts because of this concern about pre-symptomatic transmission. And if you could kind of instantly let people know as soon as a test was positive, all the contacts, and they all self-isolate and so on, you can have a big effect just by doing that. I think the practical difficulties in terms of getting enough people using the app, actually getting people tested quick enough, the problems with that paper, the assumptions that they don't really deal with, and which mean it's probably not going to work nearly as well in practice.
Right. Thanks.
James, thank you for that. Now, I've just had a question come through. One more question from Michaela, if you've got time to squeeze that in. Michaela asks, will we ever know the level of current community infection? New South Wales Health implied that there are still low levels of infection in the community undetected, and how would that affect future modelling?
So we don't have any magic way to detect the level of the prevalence of infection, essentially. We have very few cases, 10 to 15,000 people were being tested a day in New South Wales last week, and you would get 0 or 1 positive. So it's less than 1 in 10,000, right? So it's very low levels. And you can't, we don't have the lab infrastructure to test everyone sort of in the state, every few days in order to figure out how many people actually have it. You can try to do serosurveys to figure out what fraction of your population has been infected, but these are problematic because they're just not specific enough. So by that means that they have a false positive rate, which is a little bit too high, and means that in a low prevalence place like Australia, most of the cases you pick up will actually be false positives. The final sort of way of trying to look at this is through this idea of sewage testing. So people shed virus through their stools going to the toilet, and you can actually pick up relatively low levels of prevalence in sewage, but not enough to sort of say it doesn't have a low enough threshold to say you've eliminated. So we're not going to have a perfect way. New Zealand's claimed elimination on the basis, I think, of having about 28 days since their last community case and everyone having recovered. And I don't see us being able to sort of do anything different here.
Thank you, James. So with that, that concludes this first webinar. So I'd like to say thank you very much to James and to Neve to being present today. I'd also like to say thank you to our digital producer today, Grace Reyes, who's made this event possible. And if you are interested in applying for any of our degrees that are available from the School of Public Health and Community Medicine, the link should be in the bottom right-hand corner for you to have a look at what's on offer. So in the meantime, I'd just like to say thank you for attending today. Thank you to James, and thank you to Neve as well.